right now. As you're watching this video, you're doing something that you do about 20,000 times today. Something so automatic, you don't even think about it. But if it stops for just 3 to 4 minutes, your brain starts dying. And if it stops for 10 minutes, game over. I'm talking about breathing and the incredible respiratory system that keeps you alive right now. Hey everybody, welcome back to NurseBrain. I am Neil Brian Galva and today we're diving deep into the respiratory system, not just the basic anatomy you memorized in nursing school, but the incredible life-sustaining machine that's working 24/7 to keep every single one of your patients alive. Here's what's going to blow your mind. Your respiratory system isn't just about moving air in and out. It's a complex chemical factory, a pH balancing system, a temperature regulator, and a voice box all rolled into one. And when it fails, you've got minutes, not hours, to fix it. In this video, I'm going to reveal 3 things that will completely change how you assess and care for patients with respiratory issues. First, the hidden function of your lungs that has nothing to do with oxygen, and why understanding this could save your patient's life. Second, the secret mechanism that makes breathing happen automatically, and what happens when this system breaks down. And third, the one respiratory assessment technique that most nurses do wrong, and how to do it right. But first, let me tell you about a patient that taught me just how critical understanding this system really is. I will never forget Mrs. Rodriguez. She came into the ER complaining of just feeling short of breath. Her oxygen saturation was 94%. Not terrible, right? But something about her breathing pattern caught my attention. She was using her accessory muscles, her respiratory rate was 28, and she had this look of quiet panic in her eyes. Turns out, she was in an early stage of respiratory failure. Her CO2 was through the roof, her pH was dropping, and within an hour, she was on a ventilator. That's when I realized that understanding the respiratory system isn't just about knowing where the lungs are. It's about recognizing the subtle signs that someone's life-sustaining system is starting to fail. So, let's start with something that's going to completely change how you think about the lungs. Your respiratory system has a secret job that has absolutely nothing to do with oxygen. It's your body's primary pH control center. Every single breath you take is helping to maintain your blood pH between 7.35 to 7.45. Without this function, you'd be dead from acidosis in hours. Let's break this down systematically. Your respiratory system starts the moment air hits your nose or mouth. The upper respiratory tract includes the following. The nose. This isn't just a hole in your face. It's a sophisticated air conditioning unit. Those nasal conchi, those bony projections inside your nose, they're creating turbulence to warm, humidify, and filter every breath. The cilia and mucus are your first line of defense against pathogens. The pharynx. Your throat is actually 3 sections: nasopharynx, oropharynx, and laryngopharynx. This is where your respiratory and digestive system cross paths, which is why aspiration is such a huge concern in our patients. The larynx, your voice box. But more importantly, it's the guardian of your airway. That epiglottitis is literally the difference between food going to your stomach and going to your lungs. The trachea. This isn't just a tube. Those C-shaped cartilage rings keep it open, but notice they're C-shaped, not completely circles. Why? Because your esophagus is right behind it, and when you swallow, it needs room to expand. The bronchial tree. This is where it gets fascinating. Your trachea branches into main bronchi, then lobar bronchi, then segmental bronchi, then bronchioles, then terminal bronchioles, then respiratory bronchioles, and finally, alveolar ducts and alveoli. We're talking about 23 generations of branching. It's like an upside down tree with 300 million leaves. The alveoli. where the magic happens. Here's where gas exchange actually occurs. Each alveolus is surrounded by capillaries, and the respiratory membrane, the barrier between air and blood, is only 0.5 micrometers thick. That's 50 times thinner than a human hair. But here's the kicker. Those alveoli are coated with surfactant. Without surfactant, your alveoli would collapse every time you exhale due to surface tension. This is why premature babies often need respiratory support. Their lungs haven't produced enough surfactant yet. Now, here's something that's going to blow your mind about how breathing actually works. Most people think breathing is about your lungs expanding and contracting. Wrong. Your lungs are passive. They don't have muscles. Breathing is all about pressure changes created by your diaphragm and intercostal muscles. When you breathe in, here's what's really happening. First, your diaphragm contracts and flattens, increasing the vertical dimension of your thoracic cavity. 2. Your external intercostal muscles contract, lifting your ribs up and out, increasing the horizontal dimension. Then, this increases the volume of your thoracic cavity. And then, according to Boyle's law, when volume increases, pressure decreases. The pressure inside your lungs becomes less than atmospheric pressure. And lastly, air rushes in to equalize the pressure. First, your diaphragm relaxes and moves up. Your intercostal muscles relax. Ribs move down and in. Thoracic cavity volume decreases. Pressure increases above atmospheric pressure. And lastly, air is pushed out. But here's the clinical connection. When your patients are using accessory muscles to breathe, their sternocleidomastoid, scaleness, or abdominal muscles, that's a sign that normal breathing mechanics are failing. Let's talk numbers that matter clinically. Tidal volume, 500 ml, that's a normal breath. Inspiratory reserve volume, 3000 ml, how much extra you can breathe in. Expiratory reserve volume, 1200 ml, how much extra you can breathe out. Residual volume, 1200 ml, the air that stays in your lungs even after maximum expiration. A vital capacity is the total of tidal volume plus both reserve volumes, about 4,700 ml in a healthy adult. This is what we're measuring with spirometry, and it's a crucial indicator of respiratory function. Here's something critical. Not all air you breathe in participates in gas exchange. About 150 ml of each breath stays in your conducting airways. This is called dead space. In patients with COPD or other lung diseases, dead space increases dramatically, making breathing much less efficient. But here's where the respiratory system becomes absolutely mind-blowing. Every minute, your lungs are processing about 5 liters of blood and 6 liters of air, facilitating the exchange of gases across the surface area the size of a tennis court, all packed into your chest cavity. This is a gas exchange between your alveoli and your blood. Oxygen moves from the alveoli into the blood. The CO2 moves from the blood into the alveoli. This happens through simple diffusion, but the efficiency is incredible. The driving force is partial pressure gradients. Oxygen partial pressure in alveoli is 104 millimeters of mercury. Oxygen partial pressure in venous blood, 40 mmHg. CO2 partial pressure in venous blood is 45 mmHg. CO2 partial pressure in alveoli is 40 millimeters of mercury. Here's something crucial. Only about 3% of oxygen is dissolved directly in plasma. The other 97% is bound to hemoglobin. Each hemoglobin molecule can carry 4 oxygen molecules, and this relationship follows the oxygen-hemoglobin dissociation curve. This curve shifts based on pH, temperature, and CO2 levels, which is why patients with acidosis or fever have trouble with oxygen delivery even if their oxygen saturation looks okay. CO2 transport is even more complex. 7% dissolved in plasma, 23% bound to hemoglobin, but at the different sites than oxygen. 70% converted to bicarbonate ions. This bicarbonate system is your body's primary buffer system, which brings us back to that secret function I mentioned earlier. This is gas exchange at the tissue level. Oxygen moves from blood to tissues. CO2 moves from tissues to blood. The partial pressure gradients are reversed from what we see in the lungs. Here's the game changer. Your respiratory system is constantly adjusting your breathing rate and depth to maintain pH balance. When CO2 levels rise, your blood becomes more acidic. Your respiratory center responds by increasing ventilation to blow off more CO2. This is why patients in diabetic ketoacidosis have that characteristic Kussmaul breathing. Their body is trying to compensate for metabolic acidosis by hyperventilating. Now, here's something that should terrify and amaze you at the same time. You don't consciously control your breathing. There's a center or control center in your brainstem that's been keeping you alive since birth, and it never takes a break. But when this system fails, patients die. The medulla oblongata contains your respiratory control center. It has two main areas. Inspiratory center generates the basic rhythm of breathing. Expiratory center, usually inactive during quiet breathing, but kicks in during forced expiration. The pons has two areas that fine-tune breathing. Pneumotaxic center controls the switch from inspiration to expiration. Apneustic center promotes prolonged inspiration. Your breathing is primarily controlled by CO2 levels, not oxygen levels. Here's how it works. Central chemoreceptors in the medulla respond to changes in the cerebrospinal fluid pH, which reflects CO2 levels. When CO2 rises, pH drops and breathing increases. Peripheral chemoreceptors in the carotid and aortic bodies respond to low oxygen, high CO2, and low pH. But they only kick in when oxygen levels drop below 60 millimeters of mercury. This is why COPD patients are so tricky. They live with chronically high CO2 levels, so their central chemoreceptors become less sensitive. They start relying on their peripheral chemoreceptors and low oxygen levels to drive breathing. Give them too much oxygen and you can actually suppress their respiratory drive. You can voluntarily control breathing through your cerebral cortex, but only to a point. Try holding your breath until you pass out. You can't do it. Your brainstem will override your conscious control when CO2 levels get too high. So, how do we use all this knowledge to actually assess our patients? Most nurses count respirations wrong. Here's how to do it right. First, don't tell your patients you're counting respirations. It changes their breathing pattern. 2. Count for a full minute. Respiratory rates can be irregular. Assess quality, not just quantity, depth, rhythm, effort, symmetry. Look for accessory muscle use, sternocleidomastoid, scaleness, and abdominal muscles. Listen for abnormal sounds, stridor, wheezing, crackles, and bronchi. Chain strokes, periods of increasing then decreasing depth followed by apnea, often seen in heart failure or brain injury. Kussmaul, deep, rapid breathing, metabolic acidosis, compensation. Biot's respiration, irregular periods of apnea, usually indicates brainstem damage. Apneustic, prolonged inspiratory gasp. pontine damage. As people age, respiratory efficiency decreases. Structural changes. Chest wall becomes stiffer, alveoli lose elasticity. Functional changes. Vital capacity decreases, residual volume increases. Muscular changes. Respiratory muscles weaken, especially the diaphragm. Immune changes. Decreased cough efficiency, reduced ciliary action. This is why elderly patients are at high risk for pneumonia and respiratory failure, and why they often need more aggressive respiratory support. Watch for these signs of respiratory distress. Respiratory rate, more than 30 or less than 8. Use of accessory muscles, nasal flaring, cyanosis, late sign, altered mental status, inability to speak in full sentence, tripod positioning. Here's what I want you to remember. The respiratory system isn't just about moving air in and out. It's a complex integrated system that maintains life through gas exchange, pH balance, and temperature regulation, and immune defense. Every breath your patient takes involves the following: mechanical work by respiratory muscles, gas exchange across 300 million alveoli, chemical transport by blood, pH regulation by the bicarbonate buffer system, neural control by the brainstem. When you're assessing a patient's respiratory status, you're not just counting breaths. You're evaluating a system that touches every aspect of physiology. Respiratory failure isn't just about low oxygen. It's about the breakdown of one of the body's most critical regulatory systems. Understanding this system will make you a better nurse, help you recognize respiratory compromise earlier, and give you the knowledge to intervene before your patient crashes. The next time you take a breath, remember, you're witnessing one of the most sophisticated biological processes on Earth, happening automatically 20,000 times a day, keeping you alive without you even thinking about it. If this video helped you understand the respiratory system in a whole new way, hit that like button and let me know in the comments what surprised you most. And if you want to dive deeper into respiratory nursing, check out my video on mechanical ventilation right here, because understanding normal respiratory physiology is the foundation for understanding when we need to take over breathing for our patients. Thanks for watching, and remember, every breath matters, every assessment counts, and every patient deserves a nurse who truly understands the miracle of respiration. I'll see you in the next video. Once again, this is NurseBrain, inspiring greatness one lesson at a time.